Good afternoon, everyone. I'd like to welcome you to our first Medical Director training. My name's Barb Repkin, and along with Tara Rosario, we work in the General Practice Improvement and Digital Enablement team here at Eastern Melbourne Primary Health Network. We're going to start today's session with our acknowledgement of country. Next slide, please, Tara. Eastern Melbourne Primary Health Network acknowledges the Wurundjeri people and other peoples of the Kulin Nation on whose unceded lands our work in the community takes place. We pay our respect to Aboriginal and Torres Strait Islander cultures and elders past and present. MVN is committed to the healing of country, working towards equality in health outcomes and the ongoing journey of reconciliation. We recognise and value the knowledge and wisdom of people with a lived experience, their supporters and the practitioners who work with them, celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution they make to the development and delivery of health and community services in our catchment. Next slide, please, Tara. Some housekeeping. Today, all attendees will be muted. Please use the chat function to add your questions. These will be answered during the session, and there will also be some time at the conclusion of the session to ask further questions. We'll be recording the session, and all the attendees will be provided with the recording and a copy of the slide deck as well. Next slide, please, Tara. This is our agenda today. We'll be covering off on data quality, using coded lists, recording measures, recording cervical screening, prescribing, keeping medications current, reviewing results, recording social family history, including recording alcohol and smoking, recording reason for visit and keeping past history items relevant, and a section on My Health Record, accessing and uploading, and also 4.3 enhancements. I'm now going to introduce you to Grant Smith and Kylie Goodwin from Medical Director, who between them have a wealth of experience, almost 30 years of experience together. So thank you, Grant and Kylie.
Thank you, Barb. And welcome everyone to today's Medical Director training, specifically for the GP subset. We could be talking for hours and days on various things in Medical Director. Medical Director is going into its 32nd year this year of using Medical Director. I joined the company back in 2007 at 3.5.2.6 version, and Medical Director 2 days we had 2.9.7, I think it was in those days. So certainly industry has changed from actually putting computers on the doctors' desktops to now, doctors are thinking about going to cloud and artificial intelligence and all sorts of things. So without further ado, allow me to share screen if I may. I'll share the whole screen just to make our life easier. And let's go to, where's our slide thingy? All right, we decided from current slide. Cool. All right. So one of the key things we're talking about in Medical Director today is data quality. Our PHN is thankfully organised this training for us all. And thank you, Barb. Barb and I used to work together many moons ago in a previous organisation. So we understand the importance of data quality. One of the primary reasons for the PHNs around the country is preventable patient hospitalisations. And the way we can get that is by understanding our data, by seeing trends going through various population groups. And the PHNs are really instrumental in pooling that data across various subsets and organisations. So kudos to our PHN colleagues. Thank you, Barb and Tara. So in terms of that data quality, one of the things we want to be talking about is basically making sure that we don't free text in the software. We want to stick away from free texting where we can. I may just jump into our Medical Director software. Just loading up the Medical Director system. I want to start on the opening screen because there have been some changes in 4.3. There's been many changes in 4.3, one of which is we now actually have location at this front login screen. Previously, we've been starting to evolve the multi-location medical director a bit better through time. 4.3 has probably been the first update we've done where we've actually been able to fit in customer enhancements rather than just legislative enhancements. Things like active ingredient prescribing and e-prescribing, and all the various changes to My Health Record that we have to be compliant for. So it's nice to get some stuff in 4.3, and we'll talk more of that later. So in this example here, I'm just going to log into one of my medical centres with a password here. You'll notice that there were password changes and we had to comply with some e-prescribing changes. I won't bother you with the version numbers of e-prescribing compliance, but certainly to be compliant with the e-prescribing, we had to put in password rules where it was talking about, wanting to change a password every 90 days by default and that sort of thing. So I might take you into those areas and show you that as well if you haven't already made those changes. So potentially when you're coming into the software, you should be seeing your open patient from this screen. This is picking up your list of patients that is currently in your Praxoft waiting room waiting for you. Ever wondered where those patients are coming from? Certainly from that screen there, we've got all our normal options here to edit patients and all that sort of stuff. Let's just dive straight into a patient record. When we're going into our patient record, we get our prompts. Now, some people have got a wide range of opinion on prompts. Some say, get rid of the damn things. Some people say, look, just give me the ones I need. And some people say, whatever, it should be right, mate. Let's go for the middle ground of let's customize a few things. Some of these can be relevant. The reason I say don't turn them all off is because even if you just have the one about a patient's birthday, that's a nice one if the patient's had a birthday on a particular day. So let's just say continue using those notes. I was doing some training earlier today. This is the one about the birthday alert. It actually happens to be this patient's birthday on last Sunday. Of course, all these patients are fictitious patients, by the way, just to cover that particular admin item. So if we do have any particular Anna Andrews, these are purely coincidental. When we're getting these prompts here, these are the prompts that will often drive clinicians mad. Be aware what this is actually telling you. All right, what it's actually prompting you for, and you can turn these prompts off. It is actually prompting you to say, look, this particular medication was prescribed for a 6-day duration from the 2nd of May. Now, look, would it make sense to take that off the list, or would it make sense to, okay, the patient is on Panadine Forte regularly? These are what these buttons here are going to do. All right, so if I mark that as completed, it's going to take that off this current RX list, put that into the old scripts list, and make that a bit tidier for me. All right? Whereas if I just go through and go ignore, 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 my current RX list will actually be out of date because this particular medication was prescribed months ago and only had a 6-day duration at that point. Now you'll say to me, Grant, but when I go to do my referral letter, my medication list isn't up to date because it's still got that Panadine Forte there. Because you ignored the bit where it said, I'd like to complete this and move it over to the old scripts. So just be aware of what the prompts are telling you. All right, I know it's very easy to quickly just ignore them and go, ignore, 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 bloody prompts, they ignore me, I hate them. Just, this is trying to help you, because in the same breath after I had a clinician tell me, Graham, I hate all these prompts, they said, how do I keep my medication list more up to date? I mean, those prompts you just got rid of, they're there to help do that. So once again, I'll just reiterate, have a look at the prompts. It does take you all of a second or two, but it is there to help you keep your data cleaner. All right, and that cleanliness of data is there to help make your life easier when it comes to making those letters down the line. Okay, let's do the wrong thing here and go ignore, just for training purposes. I don't expect you guys to ignore from now on. All right, so when we're coming into the program, most of us are used to seeing Medical Director as current RX as our load screen. All right? And us as clinicians, that's a good screen. You know, we look at a particular medication list for a patient and we can pretty much tell, you know, what problems they're having, what issues we're addressing, what particular medications may need updating, that sort of thing. I'd like to suggest there's some alternatives. For our staff members, I'd certainly recommend for our practice managers, that sort of thing. I know I'm not talking to practice managers today, I'll talk to them later in the week, that the progress notes is a good screen for admin team to get into as their base screen. You can actually modify where you're coming into as a user. We'll talk about that in half a sec. What I'd like to suggest for clinicians is potentially to be looking at this summary screen as a landing screen. It has here your medications that you're used to seeing on that main screen there, down bottom left. It also has their past history, we'll talk about that in a sec. Our immunisation, bit of a hot topic the last couple of years. Someone mentioned COVID or something. So then, of course, we've got our family history and our social history there. Very important for accredited practice, which I'm sure most of us are accredited practices. Now, I don't particularly necessarily expect you as clinicians to be entering family history or social history, and many of you will know your patients. You gave birth to their children, or you've known them for many years. So I don't necessarily say that but it is an accreditation item, and we do want to make sure that we have, potentially if we have registrars join the practice, to share some of our knowledge. We might say that, the patient's daughter lives in Perth, or their son lives in Adelaide, or whatever the case may be. And that's just, once again, to get a more holistic view of the patient. Of course, our past history item here, quite often our past history items are a little bit cluttered, let's call it, for lack of a better term. Once again, the whole idea of this screen is just to give us a bit of a data look at the screen, because not only do you know your patient very well, but what's the data doing? How are our immunisations looking? Was there immunisations that I know I did that didn't go up? Was there immunisations done elsewhere? Have they done a flu vax somewhere else that I was looking to give this patient a flu vax, but suddenly I'd go check, and I can go check in the immunisation area over here what's actually happening on their actual AIR record. We'll talk about that shortly. So coming back to our summary screen here, on the past medical history there, I always like to make a suggestion potentially of, maybe just having a look at 2 items on the past history list and see if they're relevant. Don't go through and do the whole thing. Like, it's probably going to take you 10 minutes just to do the past history review. Just pick 2 things. Is there a cough that you put in there from 2020? Is that relevant? No. If it's, if it formed a pattern, it may have been relevant, but is it relevant now in 2024? So that's just a way to, once again, to help us to keep the records clean and once again make our lives a little bit easier when we're doing referral letters and that sort of thing further down the line. All right, any questions at that stage there, Tara? We good? No, we're good, fantastic. All right, so when we're going into various areas in here, what we don't want to be doing when we're going into the progress notes, we don't want you to be typing in their blood pressure here, 120 on 80. Bad, Granty. Bad. Don't do that. All right. Where we want to be doing that is from our examination button in here. All right. So down the bottom left there, we've got the examination button there. Come into our examination area. If I want to do a blood pressure there of 121 on 82, just for differential sake, we'll go save there, and you'll see that's bringing into my notes there already that particular item much quicker, much more holistically than just looking at 120 on 80. Now, we know that 120 on 80 means probably, but in terms of how that's going into our notes, how that's going to be looked at later, if I want to pull in data into letters and I want to bring in, say, some historical measurements, because there's been some changes in the historical measurements area of the templates. Remind me if I don't touch on that one, Kylie, to touch on the new template field about the recent measurements fields. So certainly making sure that we go into those examination areas, put in the appropriate items in there where appropriate. Now, I don't necessarily recommend doing the whole drawing thing. That's not something I tend to find draws much traction these days. Some people do get into the drawing thing. What I tend to find happens a bit more often is people will take photos on their phone and then they'll attach it to the computer and upload that way, which is not that tough. Depends on your IT skills. Some people are okay with that, some people aren't, so I shouldn't generalize. So in terms of those particular ones, the other one to be aware of there is the toolbox, I think, up here in the tools. And when we're coming into our tools area there, we've got this toolbox area. Of course, we do have all these particular areas shortcutted. I don't expect you to remember the Control-Alt-C for the cardiovascular risk. But then again, if you're a cardiologist and you tend to use that a lot, it might be something that would be a benefit for you to remember. So just keep you aware that those particular shortcuts that are there. I have seen some, some absolute magicians with keyboards, dancing around software where I was hard pressed to catch up with where they were going, and it was really impressive to watch. And usually that's through those keyboard shortcuts. So if you want to speed things up and how you're putting in your data, people talk about, we'll talk about AI a bit later, I think. But certainly if you're using your tools well, I think that the gap between good usage of tools and AI potentially are a smaller gap than not using your tools well and then picking up AI. I think there would be a big gap there potentially. But if you're using the tools well, I think there's there's an argument to be said that you'd be pretty quick as is. So as I say, let's say we'll have a look at cardiovascular risk as an example. We have the two different calculators here, depending on your school of thought, depending on your usage. Some people use this as a counselling tool with the patient. For example, they may use a relative cardiovascular risk, and then they may change, if they're talking to the patient currently smokes, 25 cigarettes a day. I was going to make something like 120, but who could afford 120 cigarettes in a day these days? Maybe some of the rich people, but wow, I don't know how people could afford that many cigarettes. But certainly if we can then change that and we can start to then modify various values, that can be a useful counselling tool to patients, depending on what your school of thought is on how that works or not. Obviously, some patients wouldn't care whether you show them a graph of where they go from red to green. I'm not giving them a cigarette, doctor. That might be, a different conversation to say. But these are the tools that are available to you. You're recording these data, and it can be used in that counselling way, or just only purely for your own data calculation purposes. And of course, we're all about making sure that data is good and clean. All right, now we've talked about good and clean data. What is unclean data? That 120 on 80 is unclean data because it's not entered anywhere. Things like if I go into my reasons for visit, please do not do free text here. Whatever I write here in this free text area, medical director has no idea what I write in that free text area. If I write NIDDM here, non-insulin dependent diabetes mellitus, then it won't code it as diabetic because it doesn't code anything in free text. If I then take that out of there, put that up into my pick from list area here, which is the far better way of doing this, and use the same NIDDM, then I can go right, NIDDM, chosen, hit my OK button there. It is correctly recorded now. So if I record something that's going to incorrectly interact with a patient that is NIDDM, then it's going to warn me and say, hey, doctor, this particular patient, don't forget, you flagged him as NIDDM. Are you sure you want to prescribe that medication? All right, and that's what the whole idea of these computers there is, to help us to make these decisions, decision support tools. All right, you guys, the doctors, you guys make the decisions. We're here to help you do that. We're supporting you with those decisions, but we need to help you to help us by putting that data in the right place. Okay, so in terms of that side of things, recording cervical screening. Now, in terms of recording cervical screening, there's a couple of different ways you can record the cervical screening. And I'll just need to mention as well, my colleague Kylie's on the call with me, and she's done a fantastic slide deck. I'm not going to go through the slide deck today, but it will be available after today's session, not necessarily today, but it might be later in the week, whatever the case may be. It's up to the Eastern Melbourne team to look after that side. But certainly there'll be comprehensive notes in the slide deck. When I looked at the slide deck, I had a panic attack thinking there's no way I could read through all those notes in an hour. So rest assured that the slide deck is far more comprehensive than what I'm talking about today. But in terms of recording those cervical screening and that sort of things, simply coming into the patient's record, when you've got those, usually it's coming in via the holding file, and you can right-click on the holding file entry and go in from there. There's also the ability, now Kylie, remind me if you could, where was the other way I go in from the patient's file to do a cervical screen? I think it was it in the toolbox? Do it from? Kylie dropped out on me. Don't leave me, Kyles. Don't leave me. Was it patient? No. It'll be in the slide deck. Trust me, guys.
Grant, I think can you go in through the tab, like the little tab where it's got cervical screening there?
I think it might be right.
And then you can add it from there. Somewhere?
Yeah. No, that's
no.
Let me have a look on that one. For 2 shakes for lamb's tail. That one. Double check that for you guys. Not that one. And go to cervical screening. Where are we? Aha. Cervical screening and plus from there. Okay. So simply adding onto there or right clicking on the cervical screening tab as well. Right. Both ways we can add in there. As I say, normally where it's coming in is from the holding file. In the holding file, you have a right click option there to enter in the cervical screening result there, which will bring up this exact same screen where you'll record the appropriate result, whether it's atypical or non-atypical, as the case may be. Reselecting from, there was a question there I saw. Was that one? Reselecting condition from, not selecting from free text. There is no postpartum hemorrhage to select from. Cool. I will also make sure to include for you the email address you can send those particular requests through to. I won't give the email address today because I confirm I'll get it wrong, but I'll make sure it's included in the FAQs on the slide deck for what they call the editor. There's a team within the Telstra Health unit, which was previously our AusDI unit, and AusDI is the equivalent of MIMS in that respect. Ours is better than MIMS, don't take me down that particular route. But certainly from there we record the appropriate screening result as according. All right, so in regards to that side of things, I will move into the prescribing and keeping medications current. When we're prescribing, of course, going usually into our current RX tab, there's a couple of different ways we can do this. If you're doing it straight from this tab, usually people will go either new item or they'll potentially click on the RX button up here. I particularly like the RX button up the top there, mainly for, seems messy, some hospitals not on board. Do you agree? Yeah, I'd agree that some of that is messy. That's a fair comment. So in regards to the current RX there, with keeping this list current, as I say, that particular prompts when you're coming into the program is a critical part of keeping this medication list current. All right. If we do, however, of course, do what most of us do and go ignore, ignore, ignore on the prompts as we come in, just as a habit, because we don't even know we're doing it anymore, then we can come back into here into the current RX list, right click on any particular item there and cease item. All right. At that stage there, I'm going to put in there the reason for cessation. Choose the appropriate list. Now, of course, if I do choose an allergy or an adverse reaction, then it will prompt me on the appropriate screen after this for the nature of the allergy or adverse reaction and what was the severity of that reaction if it's appropriate to do so.
Sorry, Grant, can I jump in there? We just had a question there. For the re-entering cervical screening test result, is there a way to select that this CST is a self-collect with a HPV detected?
That's a good question. Good question. Let's have a look. Enter cervical screening. Is there a way to select the CST as self-collect? Good question. Good question. We could potentially put that through as an enhancement. You're finding a bit of that happening there, Jessica? Just put in the chat. Is it happening a lot, or certainly we could potentially get an enhancement on there if that's something that's happening a fair bit. Then we could potentially enhance that particular area with that if it's something that's of relevance. We'll take that one on board. Going into current RX, as I say, right-clicking there is generally speaking going to be our easiest way to cease items. If we're looking at alternative brands, alternative products, if the patient's had a reaction to Panadine Forte and we want to move to a generic potentially, or they had a reaction with that versus the generic, or the generic had a reaction and the brand didn't, that sort of thing. From here we could then choose the alternative products, alternative brands, that sort of thing as well. That'll then pull up from that AusDI list in the back end that drugs data, which I say is superior to MIMS. Same data pretty much. The bit part that makes us better is our drug monograph. But most doctors don't read the drug monograph because it's too in-depth, to be fair. So hence 99% of the time they're much for muchness. And I have right on the request form with ordering LBC that's when in the cervical screening result to direct to have to write. Okay, cool. Take them on board. All right. So in regards to selecting the alternative product, of course, it's going to bring up the appropriate list of various other pain products for Panadol, for paracetamol. So in that respect, scroll through the list. Be aware that with most of the things, a lot of areas of Medical Director, you can actually sort. So sorting the list, it can cause you problems. It can be a benefit. So if, for example, I was looking for just PBS items that I wanted to show over the counter, for example, I can click on the PBS button there up the top. That then sorts that column by that particular field. And I can then scroll down and say, right, what have we got for restricted benefit? I can go, for example, the paracetamol/codeine tablet and prescribe that. All right. That, of course, then is available on the repat scheme. That sort of thing. I can see what quantities are available, what's appropriate as a clinician to be prescribing your patient in various circumstances. All right. Prescribing, keeping medications current. In terms of the prescribing themselves, generally we'll double click onto there. This is a part of the e-prescribing compliance. I do know that other competitors don't necessarily have to go through or have chosen not to go down the compliance route of representing this particular screen. I can get it, I'm not hassling it, but we do the compliance way. In this example here, it's just re-prescribing the medication as it was last time. We're seeing the real-time prescription monitoring coming up at that point. We'll also see a slide in the slide deck later that you'll get from download, where we'll just go through and explain the various green, orange, and red flags in terms of what you should be doing. At this stage here, of course, Anna Andrews is a fictitious patient. It is picking up that we're right for that particular service here and continue. If I then e-prescribe, I don't think I've got my e-prescribing turned on here. It'll basically then give me a particular thing that I want to print. This would be just my normal script, for example. And I just hit go. And that will then be printing to our script paper on the screen. That would be normal medication there. You basically have your signature bit there. You'll sign that bit. You'll see there the important parts here are our ERX tokens there, up top right and down the bottom left, which are important for our e-prescribing, because of course then when we take this, or the patient takes this to the pharmacist, they'll generally just going to scan that barcode, either top or bottom, whichever, both work exactly the same. They scan that and then pre-fills the dispensing software. Your job as the prescriber is then done. The pharmacy then takes care of all the repeats and that sort of thing. So if there are repeats from that side of things, that's all handled from the pharmacy if it's all e-prescribing side.
Just a question in the chat again. Sorry, Grant.
Yep.
Is there anyone else having issues with the MD PDF viewer? It's blurry when viewed as page to fit, but okay when opened externally or zoom is changed. Have you encountered that issue before, Grant? Anyone having issues with that view?
I haven't heard of it.
Maybe the display settings on the computer.
Possible.
Resolution.
Yeah. If you do go onto your desktop, right click and go to display settings. If you have things more than 100%, it could potentially cause issues on other screens. So potentially if you are getting blurriness in those screens, I would recommend bringing that back to 100% because the program is written for that 100%. In the meantime, Windows has done screen scaling and done all sort of wonderful things. In the meantime, we haven't changed those fields because of legacy issues. We're having issues at my workplace and ask your item lose. Okay, that's all. Make sure they log it with support, please, Jessica, and make sure we can get that. I would say it's probably going to end up being that display issue, like Kylie has quite correctly pointed out. Okay, let's come back into MDRef. Okay, so let's go to close that screen there before they give me grief later. All right. Any other questions on keeping medications going? And normally, as I say, when you've got your e-prescribing set up at that stage, a couple of things to be aware of when you're setting up that e-prescribing. If we go into user here and go to set up users, that's also, just before I jump out of that screen, that's where you'll see that password settings there. So if you want to change the expiry date from the 90-day, which is the default setting, I don't necessarily recommend making it 0 days because that means it will never expire. Maybe 180, 365, something like that, something a bit, maybe more logical for you guys. It's your practice policy on what you want to do for your password policy. That's where you can change that. Please discuss that with your colleague before you make changes for everyone, of course. Going into that setup of users here, this particular issue is still causing us issues, and I say it's causing us issues because it's a new setting. We have actually increased the permissions available to practice what doctors can and can't do. So if recently he would potentially upgrade to 4.3 and you can no longer make changes to the letter writer or something, this potentially is what's going to be doing that. All right, because there is now user permissions in the system I've of course turned them all on for this user because this is my sample user, but usually you'll find that things like add letter writer, edit letter writer templates are actually turned off by default now in 4.3. All right, so if you potentially are coming across this issue, we go, I can no longer edit templates in MD, and I could last week when we're on the old version, but I can't on the new version. That's potentially where you need to go. All right, so into the setup users, manage permissions, and just modify that. I'll just have a look to see what I've got on this one. I think that would be a fairly bog standard one. No, I'll change that one for that one.
Just to let you guys know, you may not have access to get into this area, so you may require your practice manager or a senior to be able to update it. So if you aren't able to get into this section, just let someone else.
It also raises another quick one there is restricted access patients. A new change for 4.3 is that we can actually have patients with restricted access. This is basically, it was originally designed for practices with smaller country practices where you might have multiple patients in the database that are staff members, and you may not want potentially Grant Smith to have Kylie looking at Grant Smith's patient record. Even though we work together, I don't necessarily want Kylie to be looking at my record. So we now have the ability here in Medical Direct 4.3 to actually go into a patient's file. I'll just have to, just open up the patient file there. And you'll see now when we go into the patient record, all right, now really good little trick here, top right, in between the patient photo and the edge of the demographics, if you double click there, will take you into the patient details. All right, Control D also does the same thing. And you'll see that you've now done the bottom right here, you'll see access restriction. All right, users with restricted access permission can access this patient or regular practitioner only, and that's where I flag who is the regular practitioner for this patient. All right, now it is possible for a doctor that doesn't necessarily have access to that to go into a patient's record, but we can actually then access, there is the wall of shame we call it, where you can actually then see on the list who has actually gone into the restricted access patient log. So you can see who has gone into a file and go, Barb, you weren't supposed to be going into Grant's file. Why did you go into, oh, he'd had an emergency. Okay, let's go check the record. And there, oh, okay, there was, okay, all right, no worries, all good, no problem, sweet, good as gold. Otherwise, there could be a drama. All right, so that's a fairly new feature in 4.3. But we'll move on from there. All right, in terms of reviewing results, there's a new change in terms of changes to 4.3 in this respect. We're used to our check holding file. Nothing new there. That's no changes. Let's not take you down that route just straight away. I want to take you into a patient file first, because the difference here is that when I go into this patient's file now and go into that correspondence area, there is a new button called check the holding file for this current patient. So basically that opens up the opens up the general holding file, but then applies a filter onto the patient, onto the whole holding file for just that patient's file. All right, so new button there. Of course, if we go back into the check holding file, the old way we used to do so, if you have multiple entries in this area here, if I had 3 or 4 different doctor diagnoses in this area, and I don't necessarily want to have 3 different doctor diagnoses, highlight all the entries there and hit the little chain link button there, and that will link all those particular entries to you. All right, if you accidentally get it wrong and include Kylie in that list instead of diagnoses, you can then use that button next to it to then go through and fix that later if you need to. So don't panic. So we're not breaking it entirely. All right. So when we're going into the holding file, a couple of things to be aware of is the important one, in my opinion, here is our preview up the top left here. Where are you previewing your results? All right. Quite often, some people would prefer to have their results previewing here on the right-hand side. All right, and rather have that, maybe looking a bit like that. Some people would prefer to have the preview down the bottom there because they'd like to have a bit more access to the information up the top. Neither of them are wrong, and you can change them second to second, whatever appropriate for you. So when we're in that particular screen there, we of course have our most important buttons down the bottom there is our return urgently, discuss, no action, and action buttons. All right, when we're looking at those, of course, we'll tend to use the no action, discuss, and return urgently buttons is what we tend to use. Some practices, depending on your level of complexity, may well use the action button there. Let me just put this under one of the Andrews family, otherwise We won't be able to do anything with it. All right. So at this stage here, this enables me to then add my own notations. All right. With those notations, if you've taken a quick note on that previous manage permission screen, there is actually now permission that you can't add these notations potentially. Right, because I know that in the past that quite often we have found doctors that didn't necessarily know how to use the system very well, rather than sticking to the no action, return urgently and discuss button, might put in there, discuss with nurse Grant in 3 weeks' time, and put that as the notation. Now, it's not necessarily a wrong notation. It's not making life easier for everyone further down the line in 5, 10 years' time, when this particular notation is still in our system 5 to 10 years down the time. So please just have a chat amongst yourself and your colleagues as to what notations you want to use. Things like, you know, nurse appointment 4 weeks, whatever works for your practice. All right. The important part there is that you have to have a protocol for this, and I would certainly recommend sitting down as a practice and working through your protocol. And usually we'll do that for accreditation, but make sure that you have a fairly robust workflow sheet on that. All right. So in terms of, we're going into social history, family history, including alcohol and smoking. In terms of that holding file there, as I say, the important bits there, those actioning buttons down the bottom there. Depending on your practice, some will do the add recall first. Some practices will use the recall list, some practices won't. Quite often practice will just use the action items list. I'm not going to go through that particular drama today, but it's up to you and what your practice wants to do as to how you do that. And of course, to further complicate matters, you have things like Hot Doc and Health Engine and AutoMed and those sort of things also plugging into these areas that may be responding to various inputs like discusses and return urgently as well, which could then, you know, further muddy the waters, let's say. It's about having Yep, Kylie?
So I'd also like to mention that just making sure that that clear filter is greyed out when you do come in here. And where it does say just below where it's got the preview 1 record or 1 record, that may say that there is 10 records currently there, but you're only viewing 1. So just to make sure that when you do come in here, if you do notice that, that's also beneficial because you may be only looking at partial information. And if you're filtering partway through, something may have dropped in as you're in there.
Great, fantastic. And on that particular filtering there, what that's basically happening there on this screen here, you'll see that I have a black diamond next to my date collected field. That means that this particular screen is being sorted by that field, right? And depending on which way that arrow is pointing, whether I'm clicking up or pointing down, is where it's going to be going oldest first or newest first. All right, you can reverse that depending on what you're looking at. All right, I can also use that filter button next to it, where I can then filter out certain values. So depending on the field, I may well be able to filter certain things. Like I might say, I only want the results in the last 2 weeks, for example. All right, hit OK. We'll see that result will disappear, and that's where Kylie was talking about there. That clear filters button now goes black, because there's now something that's been occluded on the screen. I've now got 0 and 1 there. I've now got highlighted columns are filtered. Just be aware that if I've got that clear filters button on there, if I do not expect to have a filter here, do yourself a favor and hit the clear filters button. Get the filter off, unless you need it. If you need it, then sure, keep it. But generally speaking, get rid of the filter unless you've got a particular reason why it's there. All right. You can move column orders around. You can move, notations closer and that sort of thing. I'm only changing those settings for me. I'm not going to change for everyone in the practice. All right. Barb wants hers in a particular way, then Barb can have hers in a particular way. I want mine in a particular way. I can have mine in my own particular way. It's not going to affect anyone else. All right. But be aware, of course, because sometimes we get busy. We have mice sitting on desktops, and we might accidentally left-click something, and it might happen to be on something like a comment field, and it's now going to try and sort by a particular field that I wasn't expecting it to sort by, and my list will look out of whack. So just be aware of that when you're in those particular fields, because there's a lot of fields in Medical Director, and these truly are a blessing when you get to use the filters well. They're awesome. If you use them badly, it's not good. It's not a good day. Okay, so let's move into that social history. All right. The easiest way to do this is from the summary tab. All right. when we're in the summary tab here, I can simply just double click in the family history area. It will open up the patient details area to the appropriate point and allow me to start entering in some family history details. Let's say daughter lives in Perth, because it's just easier to type in Adelaide. If I want to put some social history there, I might say, does lawn bowls Tuesday and Thursday. Save. Nice and easy. Some practices like to put a date and an initial on there. Probably not a bad idea, because like, when's the last time, we checked that the daughter lives in Perth? Whereas if we go into there, double click back into there, put my initials there on the back of it. I'm going to say DA as in Dr. Diagnosis. Today is the 6th of August, 2024. You don't have to do dates. Entirely up to you. All right. But of course, then it knows how up to date that is. It's the old story of good quality data in, you get good quality data out. All right. And the person responsible for this data is you guys. All right. Okay, so in regards to the longer way, if you don't want to go there, and I'm from the progress notes here, for example, and I want to update that family history up here into the patient details shortcut there, the double click into the nice big gray area there, click into my family/social history area, and once again, type away. Okay. Alcohol and smoking. You can either, once again, at the top here, you can double click into the appropriate area here for smoking. You'll see the question mark smoking. It means we haven't recorded a smoking value there. Double click into that area will take me straight to the smoking area. All right. Alternatively, click across the alcohol area and do the audit C assessment as appropriate, or put in the appropriate smoking values as appropriate. All right. Better to put them in here than put them straight into the progress notes, because when I put it in here, it will put it into the progress notes for me. All right, so it's saving me double handling. Okay, recording reason visit and keeping past history items relevant. I reckon that summary tab is still the best thing to solve this problem in terms of recording reasons for visit and keeping past history items. This bit here is the best tip here when you're looking at that particular summary screen there, looking at past history items there. Just try and look at two things. You choose which two things. It doesn't matter. Whether you go from the earliest or you go from the latest. If the patient has obvious issues, I wouldn't be talking about addressing obvious issue. The patient has a particular problem, then I would say it's still a problem. Don't say, are you still suffering from that issue? Obviously, yes. So obviously have exercise some, I hate the term common sense, but we'll just say exercise some common sense in that particular respect. Recording the reason for visit, of course, generally speaking, in our progress notes here, we have that reason for visit here. There is actually a setting, and I would once again discuss that with your practice manager, whether you have it on or off, for you to actually get a prompt for a reason for visit if you haven't put one in. All right. Controversial one. Most clinicians are pretty good with putting in reasons for visits, so generally you don't have a clash there. It's usually your practitioners who are not so good at putting in the reason for visit, don't like the reason for visit prompt. Funny that. We'll go into the tools area here. Going to options. If you don't have access to this options area, it's related to that manage permissions area you saw us in before when we written user and set up users manage permissions. All right. There's an options editing there. So if you don't have that options editing, you'll need to probably have a chat with your practice manager or practice principal who will have top level access. We'll be able to turn that options editing on for you. That should then bring you into this screen in here. From this screen in here, we want to make sure when we're looking at that one there, potentially we've got there the progress notes, all right, and we've got there a where are we?
Is it the prompt
No,
to say
it is. It's clinical. My apologies. Mandate entering a reason for contact for every consultation. Right? If you have that on, basically what that means is if I already put in the reason for contact, I'm not going to get a prompt. I'm not going to get hassled by the system. But if I try and get out of a patient's record where I've made some changes on the file, just go in and have a look at the file for whatever reasons I need to have a look at something, but not necessarily make changes on the file, I won't get prompted for a reason for visit. But if I've made changes on the file, I've updated a result, or I've had a look at a particular letter, or sorry, changed a letter, reprinted a letter, done something like that, then it will prompt me for a reason for contact for that consultation. I would probably recommend that one on, generally speaking, certainly a good one for general accreditation purposes. And this is also the main tab here. What I was talking about at the outset, we're talking about changing where you're coming into the software. All right. When Medical Director was born way back when, 32 odd years ago, it was prescribing software. Although it's arguable whether it's prescribing software or pathology writing software. It's arguable, depends who you talk to. But certainly, current medications is the out-of-the-box setting for Medical Director for 99% of users. Potentially look at for your nurses in the practice, and I'll be saying this to the nurses tomorrow. Summary where I'd like to see all the nurses go, full stop, end of story, do not pass go. Whereas for clinicians, yourselves, you look at the software differently. All right, the way you look at current medications is in a very different way to other users using software. So if you really like the current medications, I'm not going to fight you. Stay with your current medications, that's fine. But I would like to encourage you to think about summary because it does give you the opportunity to get a more holistic look at the patient's file and have a look at some of those other data areas like the family history, the social history, the past history, medications, preventative health, and of course immunizations. So once we hit save on that area there, if I now have that saved to summary, if I now open my patient up, it should now of course take me straight into the summary area rather than last time we were in here. It was asking me would I like to go straight into the current RX. Okay. All right. Okie days. 4.3 things, a couple of things we want to talk about. Kylie, do you want to talk about a couple of things in 4.3? I've done lots of talking today.
So as Grant did mention earlier, we will give you a slide show. What I'll do is I'll just quickly go through and share my screen. So what I have put together is a full slide deck with all of the new improvements. So each of these that are listed currently will be a slide. So Grant, I don't think you mentioned the emails, but you can now send email directly from either the correspondence, documents, letters, or results tab directly out to a patient. And you can also pop in a password protection there. We can also import emails as a letter.
Just on that one, Kyles, just on that one before you go on, it's also now as a PDF, whereas in the old days it was an RTF, whereas PDF's much better, whereas the patients can't edit the PDFs like they could in the old days and give themselves an extra week and a half off work, which would be great, don't get me wrong, but it's now as a PDF, so a lot harder for patients to modify it. Sorry, Elle, carry on.
No problem. So as these slides will all be coming out to you shortly as well. What you'll see is that we've got the changes in the immunisations as well as going through, and I've added some extra information there. All of these updates to the 4.3 will be required before the 5th of December. So if you're finding that some of these options that you see in these slides aren't available at the moment, that would be due to the fact that your system hasn't upgraded. So at the top of Medical Director, you'll actually see what version you're on. So if you're still on that 4.2, all of these new features won't be currently available. We also have a mini. Oh, sorry.
Sorry, there's just a question in the chat just saying a quick rundown on how to send the letters/documents.
I might jump in on that one if I could, Kyles. I might quickly jump in there and quickly share a screen on that if I may.
No problem.
Just to answer that question directly, because I think it's a good one. Share screen. All right, so there's a couple of different ways you can send the email. If you've already created the letter, you can do it directly from the patient's file where I am now. Simply right-click on the particular result there, or sorry, my apologies. Up the top there, you'll send email, and you have a drop-down there where you have password, protect attachment, and send email. If you have multiple letters, you can do that as well. So if you have a multi-select there, you can also then multi-select there, do your send email with password protect. Potentially, if you're doing it from the patient's holding file, from the patient's letter, my apologies. One of the changes down here, and I'm sure Kylie is going to talk about this shortly, was the improvement in the number of quick launch buttons we have down the bottom there. You'll see I've got down there DBE form and spec refer and that sort of thing. You can actually now have up to 10 quick launch templates down the bottom, whether they're templates from the letter writer or they're URLs like the green book or red book or The Age or Sydney Morning Herald or whatever particular website you like. So from there, if we go into that particular letter, I'll go into the specialist referral just for argument's sake. We'll choose anyone from the, I don't have anyone in my list. It's okay. We'll just go cancel. Okay, our letter.
Thanks, Grant. While you do that, just another question came through saying, my understanding is that if I use Argus and have it set as my default mail client, I cannot send emails to patients. Is this correct?
Correct. Yeah, it's correct, because Argus is hijacking your email client. So have a chat with Argus if you want to do that. Certainly from here, when you're in the actual patient's file here, you'll actually see at the top here, I've actually got a little send email button there. I can take it down that particular pathway, and we'll then do and I've got the ability to set there as a password protect, and it'll give me the password there on the screen. And you can actually now have there's another area which I won't necessarily show today, where it actually gives you the ability to customize the template that goes out with this email. And you can have in there that the password is the date of birth. But certainly, Kyles, I'll hand back over to you. My apologies, mate. You're on mute.
Problem at all. No, that's okay. Sorry about that. So basically, we also have a new window now that you've got your floating progress notes. So you can turn this on or have it off, and that will allow you, regardless of where you are in the product, to be able to go through those progress notes and start typing them in.
The whole idea of that was when you're halfway through doing a pathology request, and the patient says, "Oh, and I had a panic attack last Thursday." Rather than you trying to remember all this in your head, you can actually pop out your progress notes, record it quickly in the notes, and then continue on doing your pathology request. Carl?
So as Grant just mentioned, that's the next slide that he just ran through a minute ago in regards to the different types of navigation buttons that you've got down the bottom there. So as you can see, instead of having those two, you've got as many as you want. So based on your workflow, you would just set that up. Rather than just giving you the new shortcut keys, I just thought I'd go through and add each of them. So for all of the different ones that we have available. So as Grant said, there are some wizards out there that really go and utilize these to the fullest, and I don't have time to, but I know definitely I try to add them into each slide just in case you are one of those wizards out there. So we've also got a new area in regards to next of kin. So potentially if these details aren't provided to your practice, there is a tick box now, and then that way for accreditation purposes and things like that, it does show that you're trying to collect this information rather than just having it blank looking like it started missing from your end. Okay, and same with the emergency contact as well. It's in a similar area, but I've just created a different slide just in case you're going, oh, well, I just need the emergency, I don't need the next of kin or whatever the case is. So I've gone through and added all these in. So now you can see that we do have updates on all of the gender labels and all those sorts of things available in Praxsoft and Clinical. So any of these relationships that the patients have will be able to be now updated and added into the system to be a lot more clearer. So as Grant showed you the patient holding file, I've just gone through and added all of these in so that, once this session's over, if you don't have time to go through the videos, you'll be able to quickly come in and have a look at these guides. So I understand that, you'll get a list of all of the improvements, but you may not actually know what the next stages are. I know that we went through, obviously, the paperless electronic prescriptions, but how do we delete them? How do we cancel them? So it's also good to have that intel and information on what to do next as a backup. So I've added those slides in as an extra functionality there also.
Hold on for a sec, if I may, Kyles. Just a quick question coming in there about from Jessica about next of kin emergency contacts could only be selected from within medical director. You should still be able to do it within Praxsoft.
You can.
This is a slightly different workflow in Praxsoft. You could argue it's a little bit easier in MD. But certainly it is possible to do that. Do you want me to share screen, Kylie, and I'll quickly show how that works?
Oh, definitely. I do have a slide for it when we get into the Praxsoft side. This is just the clinical
I'll
one.
let you go. I'll let you go. If
No,
you're aggressive, go ahead. No, you go.
Sure. So basically, obviously, all those new permissions and what they mean, I've added those in as well. Going through in regards to the restrictions on how you get access to all of that information. And then I've also put in based on, whether or not your printers are based on a server or a workstation sort of like environment and things like that, just so that, when you're in different terminologies of whether or not you're working from home or within the practice now, which seems to be a lot more frequent than what we used before, it's good to sort of know where to go and where to get this information from. As Grant mentioned when we logged in initially, having access to those multiple locations, as well as I've gone through how to set them up as well. So rather than just going, okay, well, it's great to have it there, how do I add those? So I've gone through and added all those details that you'll be able to have access to shortly after these sessions. We've actually got some really great new clinician tools coming out. So with education, smart tools and stuff like that, smart scripts. So we will potentially be doing a new webinar letting you know. So if you are having access to your sidebar at the moment, you may be able to jump in there and have a look at each of them. If you've got the sidebar turned off, maybe jump in and turn that on and definitely go have a look. So, you've got your telehealth video consults and stuff like that that are built in that you can basically be using at your practice. We do have the new research tool that's actually coming out. So you'll be able to click on, I've actually added all of the hyperlinks. So anything that you need within the actual slides that I'm sending out, you'll actually be able to jump straight onto it, how to set it up, what it's all about, and go in there. So this one here is available from the 4.3. So I've added that information in there for you as well. We do have a new partner called Cyber Clinic that's actually now available on our 4.3, and it's really easy accessible from your sidebar. So if you're already
just
upgraded.
Just a note on that, Kyles, I think they might have pulled that just because there was a lot of server load. There was a stack of people jumping on the Cyber Clinic and it actually overloaded Cyber Clinic's server. So it might have been withdrawn. So just if you're jumping on to find Cyber Clinic today, don't panic. It might not be available today because, as I say, they just pulled it back from from a lot of the practices just so that the Cyber Clinic guys can work on their server infrastructure, because it went really well. It went gangbusters, which is great, but I just had to pull it back a bit because it was overloading the servers. Carry on, Kyles.
Fantastic. We also had a lot of people asking me about how to actually export the TGA reporting. So what I've done is I've added a slide in there for you, and I'll also be giving that to the practice managers as well, so they'll have access to that information. So just in case you need to know how to access any of those. I've also added in our support hours as well as how the best way to contact us. And then I've also gone through the new updates in Praxoft. So a lot of this will be more for the practice manager side of things rather than the GP side. But what we've done is we've sort of gone through each of the new updates in the 4.3 through this.
Now, Kyles, we've got a 90-second warning, so we probably need to hand back to Barb.
No problem.
To wrap us up, unless you have anything you got last words, Kyles, because I'm pretty good. You've done a fantastic job. Thank you. Barb, over to you.
Or Tara.
It'll actually be me. Thanks, everyone. So hopefully you can see my screen. So just letting everyone know, thank you, Grant and Kylie, for those wonderful presentation and that wealth of information that you have, and that pretty stacked slide deck that we'll be sending out. They'll have so many instructions, will be very useful for our doctors, for medical director. Letting everyone know that we do have 2 more medical director sessions coming up, so we have it for the rest of this week. So Wednesday and Thursday, that will be tomorrow for the nurses and the day after for the practice managers, as you can see on the screen. And these are the QR codes, so I'll give you a moment if you want to get your phones out and have a look at those. Otherwise, you can always email us at the PHN. Also, please do have a look at the survey. So if you've got your phones out, having looked at the events that we have coming up, please also whip your phone out to do the survey that we have from today's session. You can tell us good, bad or ugly. And also there's a selection in there for free text. If you can actually just give us some feedback, what else you'd like us to do education sessions on, what topics of interest do you have? Let us know, give us that feedback, because we'd love to talk to those topics, what your interest is as the GPs for the Eastern Catchment. So I'll leave it up there for a moment. And that's also our email address there. If you've got any questions, I will say for the questions that we've had in the chat, I'm sure that we'll send out in the post-event email any of those resources along with that awesome kit that Kylie has put together and Grant for that slide deck. And again, thank you to our wonderful speakers and thank you everyone for attending. I think we've wrapped up just on time. Everyone have a lovely rest of the day and thank you for attending.